Good afternoon. Welcome to the Royal College of Pathologists Guideline Implementation webinar programme. My name is Dr. Michael Eden. I'm the Clinical Director for the RC Path for Patient Safety and Quality. I'm very excited today to be hosting this webinar where we've got the leading experts and authors of the tissue pathways for oral head and neck pathology. They will be clarifying some of the aspects of this guideline that members might find difficult to implement, and hopefully sharing some sort of practical tips or clinical scenarios that will help guide that. And they'll also be here to answer all your questions, hopefully, as part of a Q&A session. So I'm pleased to introduce you to today's speakers, the authors of the tissue pathway for oral head and neck pathology. First is Dr. Seamus Napier, based in Belfast, who'll be presenting the presentation and be forming part of the Q&A. And Dr. Miranda Pring, based in Bristol, who'll also be part of the Q&A. So thank you in advance to both of you for participating in this session. Before we get going, just a little bit of housekeeping. So the layout of this webinar is that we'll have a presentation first. It'll be approximately 10 minutes long, with a period afterwards, probably 20-25 minutes tops, for a question and answer session. All the participants will be muted. So if you want to ask a question, and I encourage you to do so, please do so at the Q&A session. You may see at the bottom of your screen, there's a little Q&A button. So if you press that, you should be able to place questions as the presentation goes on, and we'll cover those and summarize those at the end. So without further ado, I'd like to kick off this meeting by welcoming our speakers and handing over to Seamus. Thank you.
Thank you very much, Michael. So although I'm doing the talking, I think it's important to give credit to my co-authors in this document. Paul Spade, who's now retired, had been instrumental in setting up our involvement in this, but I'm very grateful to Adam and Miranda, who've devoted quite a lot of time and thought to the process and to the revisions. Not a lot has actually changed over the years. One of the main things, of course, is the formal introduction of the word oral into the title, but it was always known that oral pathology was a significant component of this tissue pathway. It is, of course, testament to the quality of the original document that so little has changed over the time. We've removed some of the details, but really all we've done is effectively edit it. So what I would like to do in the next 5 or 6 minutes is really just to run through some of the major chapters to identify some of the main points and the key questions that might arise. So the oral mucosal biopsies form a major part of the workload of head and neck pathology. And in fact, when I'm talking about oral mucosal biopsies, the same could apply to biopsies of the pharynx and the larynx and elsewhere in the upper air digestive tract. Essentially, we're dealing with incisional or excisional biopsies, and the whole purpose of handling these in the laboratory is to provide a good H&E, which should allow us to see the epithelium, the associated connective tissues, lamina propria, and whatever else there may be going on within it. So all credit to my co-authors, but mucosal biopsies, this information, as I said, applies to head and neck as well as to oral and elsewhere in the upper air digestive tract. We're essentially looking for a good H&E that will allow us to see the epithelium, the supporting lamina propria, and whatever process there may be involved within it. Whether it's an incisional biopsy or an excisional biopsy really doesn't matter in that instance. But the point is that we should be able to make a good assessment of the whole of the specimen. Special stages, of course, can help as well. This montage is really a fungus, a bacterium, and a virus, which have been demonstrated very nicely here. And over the years, our ability to do this has improved, and a lot of these techniques, which initially began as research techniques, have now become mainstream. The essence with teeth is that we would like to see the pulp chamber, the whole of the pulp chamber if possible, and that allows us to determine if the pulp is vital and if the dentine is normal. If we're dealing with developmental disorders, then usually ground sections are required for that. The main advantage of examining teeth for developmental defects is to allow us to exclude them. Most information that's of value to clinicians is knowing that teeth, in fact, do not suffer from a developmental anomaly. With regard to odontogenic cysts, the whole point of the exercise is really to demonstrate a prominent palisaded basal layer, because although there are many, many different types of odontogenic cysts, the two that interest us most are the odontogenic keratocyst, which is demonstrated on the left here, and then the ameloblastoma, some of which can be cystic. Really what we're looking for there is, again, as well as the prominent palisaded layer, we're looking to see if there is apparent spongiosis that can't be explained by inflammation. That's often a key sign that draws your eye to other features. Minor salivary gland biopsies are usually submitted for the examination of cystic lesions. These may indeed be simple cysts, but of course the question of whether it's a cystic tumor also enters the differential. Involvement of minor salivary glands in an autoimmune disease is a frequent question. We're asked, again, important to be able to demonstrate enough lobules to see a good representation of an underlying autoimmune process. Within the major glands, they're usually submitted to us because of obstructive symptoms or because there's an impression of a swelling that may be a tumor. Blocking and sampling is dependent on the pathological process that's identified, but we want to make sure that we have a good representation. With jaw lesions, these often range from very small pieces, such as those demonstrated in on the left-hand side there, to full-blown resections. You almost don't need to decalcify the mandible, as demonstrated on the right there. You can see how large and cystic that lesion is that has destroyed it. It turned out to be an ameloblastoma at the end of the day. Within the nasal cavity, we usually get polyps. The question might be, is this a tumor? Usually transitional cell papillomas, but of course a wide variety of different tumors can occur within the nasal cavity. Tiny fragments also may turn out to be quite significant in terms of the underlying process. Again, we can have life-threatening infections or vasculitides demonstrated in small samples. So the whole point of the exercise is to get a good H&E in the first instance. A plethora of tonsils is what describes what happens in most laboratories, I think. Oftentimes these can have very subtle findings. Usually if there's no suspicion of malignancy, 2 blocks is sufficient. You can then go back to the residual specimen if you discover something on the histology and sample more tissue. Within neck lesions, where the main worry for us is that it'll turn out to be a tumor. Here I've demonstrated 3 developmental cystic lesions: branchial cyst on the left, a thymic cyst in the middle there, and then the sinus sternoclavicularis, as it's known, demonstrated on the right side. Most of these simple lesions are easily diagnosable on H&E. So in summary then, these are relatively broad guidelines we're presenting. Not a lot has changed over the years that they've been in effect. Sampling is essentially the key, and a good H&E will save us a lot of trouble. I think it's worth considering whether to decalcify small samples that may contain bone, particularly those from the jaw bones or those from the nasal cavities. I think that can also help in microtomy and providing a good demonstration of the lesions. Thank you.
Thank you, Seamus. That's great. A really good, brief and concise rundown through the document. At the moment, I can't see any open questions in the Q&A, but I had a couple of questions myself, if that's all right. The first was just thinking about if you've got a case of a known metastatic SCC in the neck. You mentioned your talk about taking a couple of blocks of tonsil, but in that sort of scenario, what would you recommend as the sort of block taking sampling approach? Would you limit your number of blocks, or would you take a different approach?
I think that's a good question. Very often the tonsil is submitted electively. It may not be abnormal, or it may not be just very different from its partner on the other side. But I think the idea would be that if the tumor is identifiable grossly, you only really need to sample it so that you're sure that you've got a good representation of it. But if there is no tumor to be determined grossly, I think the best thing is to sample all of the tonsil. Primary squamous cell carcinoma in the tonsil can be very small, and since they rarely evoke a desmoplastic reaction, they may be indiscernible, and you may not be able to tell it from the adjacent lymphoid tissues. So I think under circumstances where you can't see it macroscopically, I would suggest submit the whole tonsil under those cases.
Thank you. That's very, very helpful. Got one question in the Q&A asking, could the authors kindly clarify the role of P16 in oral squamous cell carcinoma? And specifically, they're saying, can you clarify about when you would do P16 in oral SCC? That's a bit beyond the scope of this tissue pathway, but if there's something you think you might be able to provide a response to.
Seamus. Yeah, so as you said, it's slightly out of the scope of the document because we're talking about benign processes primarily with this talk. But P16 is a surrogate marker for HPV, essentially a cheaper marker than doing HPV-ish, for example. So any tumor that is arising in the oropharynx, so within the tonsil, palate, so soft palate and tongue base, those are at higher risk of being HPV positive tumors. The other scenario that you tend to use P16 is primary of unknown origin. So if it presents first as a lump in the neck, then we would routinely screen all of those SCC lumps, are quite often cystic, using P16, often in combination with in situ hybridization as well. Does that answer the question? Very rarely we do get tumours in the floor of mouth that come up positive, but those are very unusual. Normally it's the oropharyngeal cancers.
Thank you, Miranda. Another question that came to mind was thinking about bring it back to sort of benign non-neoplastic process. In autoimmune conditions, say Sjogren's syndrome, for example, what would be the minimum number of lobules of glandular tissue that you'd expect being submitted to make sure that you could sort of be reassured you've got representative sampling for those sorts of for that clinical question?
Shall I take that one?
Yeah.
I think the answer is we would need 4 lobules. Generally, I encourage the clinicians to submit as many of minor salivary glands as they can find. They're very often difficult to demonstrate at surgery, but I would hope that they would send me 3 or 4 glands, and then within that I would like to identify a minimum of 4 lobules, and that would allow me then to make a reasonable assessment as to whether or not I thought there was a involvement of the minor gland in the underlying autoimmune disease. It's not really a trivial question. I think it's an important question because often we find in cases where tissue is submitted like that, it's because other elements of the case are difficult, and that the rheumatologists or the oral physicians who are looking after the case are finding it difficult to find evidence to allow them to offer a diagnosis, and I think if we can demonstrate something like that, then that helps them. But I think it's important not to be overstretched because minor salivary glands often suffer obstructive changes, and the accumulation of inflammatory cells can be seen under circumstances that's not an autoimmune disease. So I do think sampling is the key. Very important to get enough tissue there to offer a reasonable assessment. So I think 4 lobules is a good number, and if you ask for 4 glands, then the chances are you'll get to see at least 2.
Thanks, James. That's very clear. There's a couple of related questions to that, both relating to focus scoring or focal scoring in Sjogren's syndrome. So a couple of questions asking, would you consider doing focus scoring, or do you do it? So if there's anything, any clarification you can provide on that front?
Sorry if I take that one. So we do focus scoring locally, so we'd be looking for aggregates of 50 lymphocytes per 4 millimeters squared. So in answer, yes, we do it locally. That's why you need your good 4 lobules of tissue, because if you're just looking for 50 cells centered around ducts, then it's quite difficult to find them sometimes. So those 4 lobules are very important, and looking for lymphocytes. Yeah, I don't know, Seamus, do you use it?
So yes, the short answer is yes. We 2 years ago we transitioned to digital pathology, and it provides not only the facility to do that, but also it takes away one of your excuses for not doing it. And so in the past, I just said that sort of a minor salivary gland of 4 lobules was about 4 millimeters squared, and I would have counted the focus within that. But now I can actually calculate that very, very precisely. So yes, I do it, and digital pathology helps. But I think it's the threshold cases are the tricky ones. You know, the ones where there are no foci, they're easy, and the ones where there are loads of foci, they're also easy. But it does become difficult in the middle. So I do think the digital adds some reliability to the data rather than necessarily any greater truth to the diagnosis.
Thank you. Got another question, which I'm going to try and paraphrase. It relates to methods of decalcification. Are the authors able to, I think, provide any comments, particularly on pitfalls between the acid versus EDTA usage for decalcification? I think the pitfalls for the pros and cons of either approach. Is there anything you're able to add to that? Caveat being, I'm assuming you won't be able to give it's going to be very much context dependent, so I wouldn't expect you to necessarily go one or the other, but any comments on pitfalls on either method? Okay,
so permit me to jump in. So we use formic acid for most of the head and neck stuff, and I find it, as long as the pieces are relatively small and that attention is paid to the endpoint, I think it works very well and does allow you to recover quite a lot of immunohistochemistry as well, if you wish. So whether it's better than EDTA, I don't know, but I certainly think it's important to keep an eye on the timing. We would generally cut blocks small so that they would decalcify quickly rather than decalcify a whole mandible, for example. Often find that if you prepare it in advance with the bandsaw and produce small blocks, tissue blocks that can be loaded into cassettes and presented for decalcification, that works reasonably well. It can be difficult with teeth, because once the teeth are restored and have big fillings in them, then very often they're very sclerotic and quite difficult to section afterwards. And teeth do take a lot of time, probably about 2 weeks longer than even a section of gnarly mandible would. So whether EDTA is better, I don't know, because we don't use it. But as long as the blocks are small and that attention is paid to the endpoint, they don't sit too long in the formic, I think it works out okay.
Yeah, we would use formic predominantly as well. You don't want anything too harsh in terms of tissue preservation, but also for immunohistochemistry if you need it later on.
Right, thank you. So I've got one comment agreeing regarding the use of formic acid. So that's always good. Got one comment which is more general, just asking, are the authors able to provide a summary of the changes from the previous publication? I mean, that's probably something we can discuss after the Q&A today, Seamus and Miranda, if that's all right. Think about how we might be able to provide something in written format that we can share with fellows. So I'm just going to give it a few more seconds, see if there's any other questions coming up on the Q&A. If there are no other questions, then I think we can move on. So thank you very much both for essentially giving the talk and facilitating the Q&A session today, Seamus and Miranda. Thank you everyone else for attending and for your contributions to the Q&A session. Be aware that the recording of today's webinar, including the Q&A, will be available soon on the RCPath website, and it will be placed as a resource for our members to use, help support them with implementation of the guideline. If any of your colleagues weren't able to join us today, please feel free to let them know that they can watch it from from the website. Just a comment in the Q&A, conveying a message of thanks and that these sessions are very helpful. The professional guidelines team will be sending around a short feedback survey. We'd love to hear what you thought of today's webinar, particularly if any ways we can improve it further. Again, thank you, Seamus and Miranda, for sharing your expertise and your time, and thank you everyone for participating in today's webinar. Don't forget to check out the webinar page, tune in for new upcoming webinars related to the programme, and wish everyone a great day. Thanks very much.